Alrighty, hi everyone. Welcome to today's virtual panel discussion brought to you by the South Carolina ACHE chapter. My name is Nikki. I am your session host representing the National Office of the American College of Healthcare Executives, and we're glad you're here. Before we get started, I just want to go over a few things to help you navigate the program in our virtual environment. So for the purposes of noise control, your lines will be muted for the duration of the session. Please feel free to ask questions in the chat at any time or raise your hand at the end of the session if you have any additional questions. The event is being recorded and will be available for viewing in ACHE's Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face education credit. To earn this credit, you must be logged in for the entire 90 minutes of this event. All attendees who meet this requirement will see their credits applied within 2 weeks from today's event. We do encourage you to complete the evaluation for this event. I will post a link to that in the chat box, so please visit that link before we close out today's session. Now, to kick things off, I will hand things over to Capri.
Good afternoon, everybody, and thank you for joining us today. We're really excited for this panel. I'm Capri. I'm the Low Country LPC chair, and later on you'll be hearing from Carter, who is the vice chair for our chapter. If anybody on here is interested in getting more involved in ACHE, Carter and I will drop our emails, and you can feel free to reach out to us to be more involved. We have planning sessions once per month. Before we get going, I also want to mention that we have an upcoming happy hour networking event that's going to be occurring on Wednesday, May 24th after work. We actually have 2 of the individuals on here. Their companies are 2 of our sponsors. So thank you, Robinson Ventures, and also Carl Kennedy's company, 3D. And I'm going to now pass it on to Troy Powell, who is our moderator today. I'll let Troy introduce himself in a little bit more detail, but briefly, he is the regional president for Roper and Berkeley hospitals. And he's actually, I don't know if anybody on here has been to some of the past ACHE events long before COVID, but I do remember going to one at Roper that he ran as a lunch and learn, and he did a fabulous job. So we're excited for him to be moderating today. Thanks, Troy.
Thank you, Capri. And first off, it's a pleasure to spend the lunch hour with everyone. So thank you for the time and the participation. So excited about the panel. We've got a great group that are here and look forward to their input and really kind of an open conversation as we talk about disruption and what's occurring in healthcare. No doubt, we've seen a lot of changes, and I think the pandemic in many regards has fueled a lot of that. And so again, looking forward to their input. So again, Troy Powell, regional president, is Capri said, with Roper St. Francis Healthcare, overseeing our Roper and Berkeley hospitals. And as we look at disruption, it's certainly something that is I see tremendous opportunity in, and have been intimately involved with our hospital at home program here at Roper St. Francis. And again, I think as we see continued pressures and shifts to where patients want care and where payers want patients to have care and the needs of health systems, I think it is right for a lot of change and disruption. So let's go ahead and jump right on in. I'm going to tee up with a question, but then ask as we kind of go around to our panelists, ask them to take a moment and just introduce themselves, and then share maybe a response as to, from their perspective, as to where they're each of the questions. So first up is, as we think about disruption, we oftentimes see that within high-performing health systems. And curious to get the panelists' feedback as to what they feel is the culture, the history of leadership, the size of the systems. What are those secret sauces that are really that define high-performing health systems? So first off, I'm going to turn it over to Angus and let him introduce himself, and then give us a little bit of a response to that question.
Sure. Thank you, Troy. My name is Angus Douglas. I'm the Chief Mobility Architect at GE Healthcare. What does that mean? My role for the past decade plus has been to build disruptive technology solutions that change the paradigms of healthcare through engaging both innovative technologies and startup companies. We pull them into the GE ecosystem, and we focus around areas like speeding clinical decisions, improving patient safety, addressing staff fatigue, mobilizing care, and in general, connecting care teams across the organization. So we're very excited to be here today and to talk through this topic of innovation with you. And on that first question you had there around what defines a high-performing health system, culture, history of leadership, and so on. When I think about that, I guess one of the first things I think about is innovation really starts with people, and specifically those who are on the front lines of care, who deeply care about improving care. We used to talk about management by walking around, and really innovative organizations are really good at soliciting data. And a second thing, and this is kind of a thing we've been focusing on at GE, how many times have you tried to solve the same problem twice, right? And, you can't improve something that you can't define or measure. And so we use two things in our organization to try to improve on that. And one of that is standard work. So we really understand what's happening out there. Then the second is data. We're swimming in data, but innovative organizations are taking that step to derive insights and create insightful data that allows you to see the problem and solve problems and measure those solutions. So it's part culture, it's part being able to see where you're at and where your improvements are. And then finally, just a cross-functional approach versus silos, right? We often focus on the problems of one group and then we just sort of pass it down the line. So, we often end up creating problems for that next group. And we've got some examples we'll share about this later, but I'll pass this question along to others.
So Cian, let's hear from you.
Hey, thanks, Troy, and good afternoon, everyone. My name is Cian Robinson. I'm the president of Robinson Ventures. We're a management consulting and venture capital company. We are based in little old Hartsville, South Carolina, of all places. And that's why I'm wearing Coker University's colors, where I married a woman way smarter than me, who's the president there. So we work with hospital systems, so very blessed to call MUSC a client, all the way through the full continuum to smaller companies that are seeking to enter into and disrupt the marketplace. And so when I think about this question, Troy, I really think about culture and accountability as the two primary drivers, right? Your organization must have a cultural construct that embraces innovation and does it explicitly. And so when I think of going into different hospital systems, when I see their core values, innovation should be in there and it should be stated as such. In addition to that, there must be an accountability model. You can't just say you embrace innovation. You actually have to embrace it and operationalize it, right? And so you have to have in everybody's job descriptions some aspect of innovation and what they're doing and hold them accountable to those activities. And that is from the frontline folks all the way up and through to leadership. And so I really truly believe that you must make innovation part of the culture and the accountability model.
Well said. So Karen, let's let you introduce yourself, and we'd love to get your perspective as well.
Sure. So I'm Karen Shahady. I am with Medtronic. By background, I'm a PA and worked for a number of years doing inpatient medicine in Boston, and then moved into the health plan space at United and then Blue Cross of Massachusetts. And from there came to Medtronic about 8.5 years ago and worked with our global medical affairs team. So a lot of the work that I do has been focused on quality outcome measures. So I represent Medtronic at the National Committee for Quality Assurance's Industry Council, the National Quality Forum's MAP, Hospital Committee, and have been very engaged in value-based healthcare, payment models, and most recently around health equity. So as part of my role, I work with health systems across the country. And, when you ask about the secret sauce, the one addition, and I agree with what I've heard already for sure, especially about accountability, but engaging with the community is something that I've seen is a real, is part of that secret sauce for some very successful health systems. They make sure that, they really engage with people in the community. They understand their community. They have community advisory boards. Decisions are made with the community. so that, any innovations or novel approaches that they're trying to bring forward are fully supported by not only their employees, but the broader community in which the health system is serving. And that really helps enable some of these innovations to launch and take off. Otherwise, it's very difficult to get buy-in from the community on some novel solutions.
Well said. And last, but certainly not least, Dr. Scalea, let you introduce yourself and then share your perspective.
Thank you very much for the opportunity. My name is Joe Scalea. I am a transplant surgeon here at the Medical University of South Carolina. Previously to being here, I was in Baltimore for 20 years on and off in various cities already mentioned, including Boston. I do work with Cian in some capacity here at MUSC. Good to see you, Cian. I'm the Vice Chairman of Surgery for Innovation, and I'm the Executive Medical Director for Healthcare Solutions through the MUSC Health Arm, and CMO and co-founder of a series of different startups in both the digital health and medical device space. So in good company here with some incredible people, humbled to be able to participate. I'm going to agree, as did Karen, with many of the things said and offer perhaps a slightly more scientific and clinical view. I can provide that. High-performing health systems, I do think have a lot in common, although I think we all frequently say, if you've seen one health system, you've seen one health system. And I do believe that the more time I spend in the health systems. I'd like to add to the comments made that a willingness to fail and encouragement to fail, I think is required and present amongst high-performing health systems. Implied there is the willingness to take a little bit of risk and believe in people and ideas without complete information. And I think that that's important insofar as leadership that comes in the form of listening more and talking less, reading more and writing less, and understanding that you cannot fix problems which are, you can't fix something that's not measured. And so getting to my science comment and supporting both Karen and Cian in their comments about data and accountability, we need to know what is the problem we're solving and if it is worth solving. And that generally requires information up front in order to be as diligent and scientific as possible in order to get the best patient outcome and have the best system output. Thank you so much.
Well said. So, I mean, great feedback. And so even as I'm sitting here jotting down some notes, things that I heard were, you're right, I think Angus, you spoke to this, is that coming out of the pandemic, I think even more so, we're actually, as you said, swimming in data. And I think there's just so much there that we're really trying to process and take on. And Karen, I loved your points around, it's got to be, I think anytime that we're talking about disruptive effort, it's got to be more of a grassroots type of approach, right? It's hard to force a square peg into a round hole. You've got to really have that buy-in across the system and within those community stakeholders. And seeing your comment around just the accountability and making sure, because I think anytime there's disruption, I think with a lot of these things we're seeing now is that how is it that you gotta know where you're working to, right? And you gotta have that framework. And I think that accountability is paramount. And I love Dr. Scalea's comment around the willingness and encouragement to fail. And if folks are, no doubt, if you're afraid of failing, it's hard to be innovative and disruptive, right? So it's a great feedback. Let's pivot over to another question. What do you see as what are the steps of encouraging healthcare leaders to be more open into disruptive innovation that may threaten the status quo, but will ultimately enhance the quality of healthcare for the majority of the population? So again, how is it that we really try to encourage leaders to do it? I mean, I think we're already kind of touching on some of this, but we'd love to dig a little bit deeper there. So I'll leave it open to whoever wants to respond first.
I can start with this one because I think along the lines of where Dr. Scalea was going before around the scientific approach, I think, engaging in research and, we think about clinical trials, that's one aspect of research, but it could be, through partnering with academia, it could be community-based research, but, really taking that analytical view is, I think, critical to start, so all begins with engaging in the research, and then making sure that we have a process, that it follows a very methodical process, just like research does. Any efforts that a health system or community organization wants to take in terms of innovation has to have a real thorough process around it, and making sure, especially in healthcare, that whatever process is devised engages, I'll put patients, people in that process. So you can't just design it outside in. It has to really be engaging with the community, the patients, the families, whoever is going to be impacted. And then if you do engage in that kind of process, making sure you have that leadership support throughout the whole process, because you will fail at, doing things. You want to fail fast and fail often, and you need a supportive environment of leadership that enables and allows, and as Dr. Scalia said, encourages that. So really taking that research process, analytic-based approach to this, I think is at least one way to encourage some healthcare leaders around innovation.
And Troy, to build on what Karen was saying, it starts if you're in a nonprofit community-owned health system, with your board and your senior leadership in that explicit statement of embracing innovation, not just for innovation's sake. That then is included in something like a strategy, a strategic plan, the corporate values that gives then those folks the commission cover to implement innovation, right? And sits there and says it permits them to sit there and say, we're going to do this. And then what I think happens is you listen. And I think Dr. Scalia, you touched on that. You go out and you listen and to identify the pain points and the problems that your folks are encountering. And once you identify those pain points and problems, you come up with those active, highly defined problem statements that you can now either build, buy, whatever in there you need to do, you go out and do that. You can do external, internal. And then I truly believe that you have to have, and Karen, this is building on again what you say, a structured approach to this. I prefer in health systems a stage gate approach. So you start with, continue with sort of a research piece, a phase 0 ideation phase. You then move it to a phase 1, which is maybe an MVP, to a phase 2, to an implementation, to a phase 3, to a scale, and so on and so forth. And along the way, you make sure you engage your key stakeholders. They are the subject matter experts and end users of that innovation. And so if you engage them along that road, that path, that road, you also reduce execution risk at the same time, because inevitably somebody's got to own this, and somebody's got to continue to run this once the innovation is done. You don't just want to innovate, get it started, put it out there, and then have it die in the future.
That's great. Cian, I wanted to add to that, and also what Dr. Scalia said about risk aversion. As noble as it is, the desire to avoid risk always creates delay. And while some of that's necessary, we also need to be willing to open the door, like you were saying, to more of these pilot programs, proof of concepts, as we evolve that. Even the ones outside the comfort zone of our technology stack today. I'm working with a very large organization out of Boston where some mid-level folks know what needs to be done to improve patient safety, or at least they have a strong mission about that. But yet, due to risk aversion, they know it's going to take more than a year to get that project, approved and able to be done. So they're literally, by necessity, burying it within their own hosting and kind of owning the budget for that, when it really should be supported at the organizational level. So like Cian was saying, as well as Karen, we need to listen to those folks. And also, this is something that one of my folks that is involved in innovation said is, ROI. There are many organizations that tell us we can't consider anything unless we have a 3-to-1 ratio of return on that investment minimum. And as great as that is, it puts a handcuff on innovation. We were working over the past couple of years with Advocate Aurora up in the Chicago area on a connected health initiative. And it was so broad, and the potential for impacts and length of stay, cost of care, and other areas were great, but they were essentially unmeasurable because these things don't exist in a vacuum. We couldn't give you this rigid ROI. And we mutually adopted a different term we called value on investment, where we could define the derivative benefits, whether it's turnaround times, workflow efficiencies, reduction of hospital-acquired conditions, turnaround times, whatever, that everyone agreed on would contribute to the ultimate high-level benefits. So we adopted a VOI, value on investment approach. So, we just need to be careful not to throw out what we know to be intuitively solutions that can solve our true problems. We just need to think outside those limits.
I think those are great.
I'm going to come back to that in just a minute as we start talking about how do we size innovation. So I want to give Dr. Scalia a chance just to respond.
I appreciate that. Some brilliant comments here. A couple of themes have come up here really around risk and culture. It's very difficult to innovate if there's not a culture around accepting that there's risk in innovation. I've written down here in advance, innovation is sloppy and it's hard and it doesn't really work the way you want it to. And part of that is being nimble and being able to accept, all right, this didn't work quite well. We're going to go over here and try this. I'm going to offer kind of another view of the question. And that is to say, perhaps not how do we convince those or help leaders understand the importance of innovation, but rather asking ourselves, what does it cost if we don't innovate? The current system doesn't work. We spend $4 trillion a year on healthcare with, modestly okay outcomes that just don't compete with other first world countries. And so we can look at it as, should we innovate? But I'd actually say, let's flip that around and say, why, how can you not? Like, defend the current status quo, and you get pretty quickly to okay, I got it. We don't have all the information, but we do need to take some risk and embrace a culture because what we have today just doesn't work. And I think that's a very logical way for people to think. And so even if you're not familiar with like Cian's approach of building innovative companies kind of from the ground up, or Medtronic saying we learned something from a customer, we're launching a new product, you can say, all right, I may not be somebody who starts companies and does the research, but I know what we have doesn't work. I'm going to put trust and faith in my team and build a culture around this because that's the future.
I couldn't agree more. Anecdotally, I have I remember it stuck with me when I was in high school. My biology teacher said that when species face adversity, they have three choices. They can adapt, they can migrate, or they can die. And so as we think about disruption, and we have to, right? And because you're right, the current path and it's not sustainable. And so we have to be willing to change the status quo. Or frankly, it's going to implode, right? And we're just not going to be able to meet the need.
Troy, I would say it's not going to implode. I said we're in the middle of the implosion if we're not careful.
Very true. So, and I was just saying, and Dr. Scalia, I love your point as far as sometimes disruption is sloppy, and I've come to reconcile myself to that, I guess, in that I've realized that as we've gone through our efforts with our hospital at home program, that we found that there's totally different workflows, and we've tried at times to try to make everything fit into a box, and then I think we've realized that it can't. And it's a little bit maddening, right? Because you want to control it. But I think what we've learned on our side is that, and I'll use like our pharmacy, for example. Pharmacy has been one of these things that it's a totally different workflow for us to take care of patients that are transitioning in the hospital at home than it is to actually care for them in the hospital. In the hospital, they actually take medications, they put it into a dispensing system, and that's how we administer meds, right? In hospital at home, we don't do it that way. And so we have totally disrupted actually how that, even at just a simple workflow level, how we have to do it. And again, there's a lot of pain points, there's a lot of gnarling of teeth and everything else, but we've realized that that's just the nature of it, and we just can't give up. You got to be persistent, and be willing to continue to drive that change. So.
Can I just respond to that quickly? Because that's a great example of, you change your workflow and there are a whole bunch of off-target side effects like we would see in pharmacology, right? Just because you're not implementing a new drug doesn't mean that you're not affecting outcomes of patients when you change a workflow, right? And you can't fix what you can't measure. And so learning how to do that is smart. When people get frustrated, it's from one of two things, right? A knowledge deficit or a skill deficit. And that gnawing of teeth here is a knowledge deficit. Those patients aren't here. So how do we measure in order to change, in order to improve the outcome? And I think there's a huge opportunity in this space, a very exciting sort of ocean of blue water there. Fix that. That's a great problem to solve. And a very exciting part of healthcare.
Roy, I wanted to add to what you said too, because I think timing is everything too. And, you can go through the right process, you can have a phenomenal new innovation, and the community or the, healthcare ecosystem just isn't ready to embrace it. Maybe reimbursement isn't ready to have it launch, coverage isn't there. But then, the tide turns and all of a sudden, the environment is ready to take that on. I mean, look at telehealth. The technology was certainly in place pre-pandemic, but then the pandemic hit, and within 3 days, we suddenly had, telehealth capabilities. And so, it requires, innovation requires some patience too, because sometimes it's just that, the time isn't ready for some of these new innovations that are happening fast and furious. And, but over time, eventually they'll start to find their home.
Totally agree. All right, before we pivot to the next question, I just want to remind the audience that we are monitoring the chat and very much want this to be as interactive as possible. So if there's any questions, we're fortunate to have such a great panel here. And if there's any questions that you'd like to pose to the panel, please put those in the chat. We'll make sure we get to them. So I'm going to come back, Angus, to I said I wanted to put a pin in a point you made, which was around how do we scale or size the ROI a lot of times with innovation, and what you were hearing is that an expectation for a 3-to-1 type of ROI. I think as we come out of the pandemic, and we can size ROI in different ways, right? And I think as we come out of the pandemic, we've certainly seen a lot more disparities in care, and how we're seeing a lot more acknowledgement of underserved areas, and so when to kind of spend just a moment talking about innovation in those underserved rural types of areas. So Karen, if it's okay, I'd love to get your feedback. I know you've got the background in within health equity, and so then we can see what others have to add.
Sure. Do you want me to start, or Angus start?
Yep, you go right ahead, Karen.
Yeah, sure. So yeah, we've been doing a lot of work in the space of health equity, like many organizations. Industry has really been picking up on this, specialty societies, obviously health systems, and across the whole ecosystem of healthcare. And when you ask about some of those rural communities, it's really for any type of disparity, we've been looking at that process again. So we go back to a process and making sure that we stick to a systematic way of identifying if there is a gap, number one. So it goes back to, I think Cian had said this before, and also maybe Angus, about the data you have, and Dr. Scalia, you have to have data first to say, is there a gap? And then where is the gap? And then what are those barriers that are taking place? And really try to hone in and identify on what some of those barriers might be so that you can do something about it. And then being able to partner in the community with community resources. Nobody's doing this alone. This is really a great example where we and numerous other organizations are coming together to say, let's try to figure this out. I mentioned specialty societies. They're taking a tremendous interest in health equity, along with health systems, community partners, for-profit, not-for-profit, really trying to come together and come up with, you know, a process and a plan to address it. And then really making sure that you can remove whatever those barriers are or address them. It could be a bias that's a barrier to care. It could be a social determinant of health, you know, economic, transportation, language, you know, but and then you have to measure again. And, you know, we've already said, you know, sort of what gets measured is what's going to get that attention. And so you have to measure again, and not to say, okay, well, it failed, or, you know, we didn't, this innovation, this new solution didn't work, but rather to say, okay, that's fine. It's continuous process improvement, back to the drawing board. We want to identify, use our data again and say, where did we, you know, what didn't work? And then how do we engage people? How do we engage the provider, the family? What's a solution? And then measure it again. And it keeps that process going, whether you're talking about rural health or disparities for people with disabilities or racial disparities. It's making sure that we have that process in place. In the case of rural health, a lot of it leans on geographic data and zip codes, and, you know, really trying to see what's happening. You're using the community health needs assessment and other tools to help figure out where those gaps are. So Angus, I don't know if you want to add to some of that on health equity.
Sure. And generally more of my personal focus has been around acute care. And, you know, we're, for instance, as far as rural, we're doing an interesting project with Oregon Health Sciences, where it's all around continuous surveillance of patient populations out into the rural areas across the entire state of Oregon, as an example. And traversing the lines of healthcare provider organizations has been really interesting. But what it's done is it's allowed these rural patients to be served without flying hundreds of miles in inclement weather in Oregon, which is frequent if you've been there. So, you know, it's allowing them to get top levels of care from OHSU out of Portland to these folks. And that's sort of been enabled by this unprecedented new possibilities through ubiquitous connectivity. But the same thing is longitudinal care. And that's looking outside of hospital at home, and incorporating everything, including what Karen talks about, the social determinants of health. Those are so important. And the key is, right, how do we converge all that data across that patient journey to facilitate that seamless, you know, assessment and care of the patient. So, you know, how do we, and so that's going to take kind of new partnerships and new ways of looking, because often what's happened is that, you know, we have this fundamental set of challenges in healthcare, right? Whether it's demands on the health system, complexity of care, health inequities, staffing, you know, as well as we talked data overload earlier. And we can't solve these alone, and we need to kind of look outside our traditional areas, and specifically in areas of partnership. You know, we have these very large monolithic systems we've created as our healthcare organization has expanded. And I think we'll talk a little bit about disruptive innovation later in this discussion, but sometimes we try to limit our solutions to what we've already put in place instead of being open to new partnerships. And that's going to be essential for reaching outside the walls of the hospital and providing this type of care.
You know, Angus, you triggered something as well. I want to make sure that we mention this too, that it's important, I think, for us to look outside of the hospital system in that broader community. Yep. Supermarkets, you know, doing blood pressure screenings at the supermarket, churches, the barber shops. I mean, we've heard lots of examples of this. And now, how do we take that to scale so that healthcare isn't always, I mean, they can be affiliated through the health system, but it really has to be, you know, ubiquitous in the community, and, you know, getting out there and making sure that we have, you know, leverage telehealth and leverage other ways of going to where people are going, not necessarily asking them to come in to, you know, even a doctor's office, but making sure that the healthcare system is meeting them where they shop, where they live, where they worship, etc.
Yeah, I mean, I think that this is probably the most exciting part of where I see some of these technologies going. Part of the reason for that is I think inherent in the discussion of rural communities and disadvantaged populations is that they actually lack the infrastructure that we are trying to reinvent in more established communities. And so that's actually in some ways a huge opportunity, because without that infrastructure in place, we can perhaps more nimbly and more rapidly implement more connectivity and sort of new ways of care delivery that are going to be harder to reinvent in a more established community. According to the AAMC, 15 to 20% of all patients are in rural communities. That's a lot of American lives. And that couldn't be more true in South Carolina. What's also interesting from a medical standpoint is that this is not the same population. It's not just the same group of people dispersed into an area separate from an urban environment. These are different patients. They tend to be a little older. They tend to have, as they age, actually lower levels of insurance coverage. Educational status is different. There's higher rates of pediatric poverty and malnutrition, right? It's just a different group. It's a different group of patients with discrete problems. So I think as we think about, as we all do very academically, think about the process of innovation, which begins with insight followed by unmet need identification. What is that need that we can begin to then grow on, like Cian would do in an entrepreneurial environment? And several of them for me come to mind, but I'd sort of ask you to envision a situation where, to Karen's point around sort of delivery models and what that might look like, we have telehealth. We know Amazon has shown us that the same day you want to order a black desk or a red desk, it's going to show up with Tommy in a truck at 4:32. Like, why we can't do that with metoprolol is not totally clear to me, but it's possible. And I would say that I think some of the apprehension around doing that, I mean, we've seen major reinventions of industries of finance, consumer goods, food services, and we haven't seen that in healthcare. I think partially because if you get the tennis shoe order wrong and the wrong color or the wrong brand comes, there's no patient harm. You just wait another day for your blue Michael Air Jordans instead of the red ones. But if the patient takes the wrong medicine, there's real gravity around the outcome. And I think we've been apprehensive to get beyond the fact that that these are challenging situations if we automate them, for example, in rural communities. I do think, though, that what's the other side of that coin is there's more human error when we try to do things without automation, without technology, without innovative new platforms for healthcare delivery. And so I think it is now time, getting back to our comment about the current system just is not sustainable. It is now time to take that leap, to take that risk, to believe in our teams and build that culture and go get that vision of sort of bring the hospital, bring healthcare to you in a consumer-focused way that helps a different population of patients that exist in more rural communities.
Dr. Scalia, I just want to comment on one point you made, which is around not trying to reinvent the existing infrastructure, say in an urban area into a rural area, and say you have to fit into this model. Other examples, in Tanzania, in the banking industry, people don't have cars to get to the bank to get, to do their banking, but everybody had a cell phone. And so online banking took off in very rural parts of Tanzania because everybody had a phone. And so they leapfrogged right over the traditional infrastructure of building a bank and having a teller or an ATM machine, et cetera. They just did all their banking on the phone. And that's a great example where, can healthcare leapfrog over kind of trying to retrofit rural communities into an urban model? And can we, come up with some different solutions that will work better and faster?
Karen, I'm going to say to you that we are being leapfrogged because we are not doing it. And so I hate to say it, but I'll bring it up. I mean, Walmart has access to 93 to 96% of the population in the United States, no matter where you live. Dollar General,
Right.
Same thing. Guess what they both offer? Walmart Health and Dollar General Health. They're meeting people where they are and how they want to be met. We're not, right? In many instances. Some instances, absolutely, but we're not. And so when you think about, what are the basics, if you can get to a Walmart Health or a Dollar General, you can get primary care and chronic care management now, right? How are they transacting with them? They're not transacting with them with telehealth. They're transacting with them with text messages, because pretty much like you said, everybody has access to something like that looks like this, right? And so I really think that if we don't start to change the model of delivery and put that model on its head, that we're going to be, and this is probably a brash statement, it's not going to make me many friends, but we're going to be really expensive real estate with some very talented, highly trained people that don't have the wherewithal to continue to support that infrastructure. And so how do we pivot and start to meet people where they are is absolutely what's going to need to happen. Then there's this great question about how does innovation and health policy, and there's a confluence. And so the way I think about it is, okay, so I'm going to be the entrepreneur that usually is on the outside coming in, and I'm really going to lean on my friends here, on this great, chat that we're having as the inside, because I am a recovering hospital administrator, which is kind of counterintuitive, right? I tell you that innovation will help drive policy, and innovation is asking for forgiveness, not for permission sometimes, okay? You don't do that outside of a construct, right? So I'm not saying just go out and start doing stuff willy-nilly and carry on, right? You have to use innovation to push and drive policy while also transacting within the environment that it's seeking to change. So it's this wonderful balance that you have to come up with, a wonderful calculus. And I'll bring up the other part, that we have an impending repeal of the CON here in South Carolina, right? That's part of that pending repeal of CON is to help solve the rural calculus of how do we deliver healthcare, because there are some gaps in areas where you can't get that there because you can't get that CON in place, right? So that's an instance of how are we affecting and effectuating policy change to make sure that the delivery can happen, while also innovating those delivery methodologies and modalities that we can get out there. So Sarah, I really think it's it's a bit of both. You're asking for forgiveness, not for permission. You're trying to innovate. You're trying to drive that policy while remaining in that construct and still getting it done.
This is where, and I'll interject. First off, this is where I get excited about this, because I think as moderator of the panel here, and I'm using my air quotes here, I could step back and let the team just take it from here, right? And because I think we're certainly feeling that the enthusiasm that all of us have around disruption. And wonderful point, Cian, as it relates to how does policy and innovation, where's the confluence there? And I will say that, again, from my experience, and I'm going to go back to one of Karen's earlier points, is that this is where I think it's got to be at that grassroots level. And it cannot occur in a silo or in a vacuum. It's got to be that you're educating while you're actually going through it. And, I'll offer another firsthand experience as it relates to like hospital at home. We actually found as we were moving forward, and you had on the CMS side, there was actually an allowance for hospital at home to continue during the public health emergency. But then when South Carolina actually did not renew the PHE, then all of a sudden the CMS mandate no longer applied. And so we found ourselves actually having to, educate the legislators around it while we're at the same time concurrently building the program. And ultimately we were able to influence some policy change. And but it had to be, you couldn't just stay in your lane. You had to be reaching out and educating and bringing those within the organization and those beyond. You had to be bringing them along with you. So we had one other question in the chat, and that I wanted to put, and the question was around how do we engage with the rural health and screenings, and how do we connect as health systems with public health programs and public health departments. And I think we're seeing more and more value of that. I'll offer some perspective and then hand it over to the panel, is that I think as we're seeing value-based care continue to grow in South Carolina. We're a little bit behind the times here. And but as we're seeing value-based care grow, I think we're understanding that value. And I think this is even driving some of that the emphasis upon rural health in the underserved. And because I think we've realized that gap has probably widened and that we're having to engage. And I think it's incentivizing providers, frankly, to do it, because if you're actually having some responsibility for those areas, then you're having to develop programs, because if you have the ability to engage with a public health department, Karen mentioned churches or other civic groups, and to bring care into those areas and keep them out of the hospitals or keep them out of the EDs and the doctor's offices, there is an ROI to it, right? And so I think that we're seeing that as certainly a space that we've got to do more and more with. So I would love to get others' perspective there. Not everybody.
No. So I'm going to also maybe be, I don't know if everybody saw last week that this little hospital out in California named Kaiser Permanente bought this little hospital up in Pennsylvania called Geisinger. And they did it through a special purpose vehicle subcorp, and essentially said, and we're going to buy 3 to 5 more because we're going to create the nation's largest value-based care network. Now, if everybody is stuck in a fee-for-service model, you should have sat up and gotten high and tight real quick, because they understand how to do that. It's also why Walmart's entering the space. They understand large volume, low margin transactions. These are the things that are coming our way, Troy, right? These are the things that are coming our way, and we have to start to think about how do we offer these models to maintain relevancy, right? And so, Dr. Scalia and I are working on a model for renal care, right? What does that look like? How do you use data to identify people who are in CKD stage 2, 3A, and 3B? How do you get them into a chronic care management model sooner? And how do you maybe even glide them into dialysis, or God forbid, straight into transplant?
God forbid, get it done faster.
Right. And so, these are, and oh, by the way, not only does this add value in ROI to the health system, but the quality of life and the quality of care that this patient receives with that engagement also has been shown to go up, right? And what is the tech that's being used to manage these chronic care patients is text messaging. It's engaged text messaging, nothing fancy, right? Just straight to the phone. I mean, they have a client who's 108 years old and her daughter's 87, and they both work in this plan and find it engaging, right? These are the types of things that we as administrators and we in this ecosystem must be bringing to bear. Because as I forget who said earlier, I can't remember, I think it was you, Dr. Scalia, it was the model isn't sustainable, right? The current model isn't sustainable. And I think you too, Troy, right? Because of the amount of spend that's going on in the United States that does not get us the quality outcomes. And yet you go overseas and you see different quality outcomes with a lower spend. It's just not sustainable.
I like to provide some context per I agree, right? I think one of our challenges here is sort of, this is how do we get better? How do we fit? How do we, and I'm gonna use some of Cian's words and paraphrase them. How do we actually become relevant? Because we have actually become irrelevant. And the problem is the patients still need care, right? So how do we actually get ourselves where we need to be? Clayton Christensen, who's several quotes of his are in later versions of the questions, as I recall, or some of the prompts, would tell you that an organization really cannot disrupt itself by definition. And so that puts us in an interesting position, because if we're providing healthcare with these large systems, how do we remain relevant when we know both patients need care and there is disruption required? And I think It's by actually, and perhaps paradoxically, welcoming elements of competition to show us what the next steps are. Again, it's just thinking linearly, the system is not sustainable. There are new innovative ways to do things. And we probably ought to be meeting patient need and understanding where we fit. A quaternary care center like the Medical University of South Carolina or any of these large systems probably ought not act like a primary care provider in the emergency department. That's probably not a great use of time, resources, or and whatnot. Performing liver transplants and heart transplants and kidney transplants, that's sort of what we do, right? And so perhaps there is a new quilted version of a far more both economical and quality-based model that leverages value-based care to get people need the care where they need to get it, using technology like the text messages Cian was talking about, and then using the current structure where it is really relevant. And so that may not be a popular way to look at this at the ACHE, but I do think from the patient standpoint and from a quality of care standpoint, it may be important.
And, you know, along the lines of policy and what's driving what, I mean, it's aligning incentives to this innovative work. So here in Massachusetts, when I started my career at Blue Cross, where the alternative quality contract, which is a value-based payment model, initiated, you know, back in the mid-2000s, that's where once the provider groups were financially accountable to a panel of patients, innovation really started to happen, and there was more openness to testing out these new models, because they didn't want to do primary care in the emergency room, which was expensive. They would be more open to doing text messaging to patients because they didn't need to bring them into the office. Quality was critical to make sure that you know, we had guardrails in place to ensure that it wasn't just old-fashioned capitation from the 90s, but rather, you know, value-based care. But some of the innovation goes hand in hand with, you know, novel payment models. And, you know, the question is, can it be left to payers to do that? Because right now it's up to either the payer models putting out value-based payment, or a Medicare, you know, CMMI, or, you know, Medicare payment models that drive it, as opposed to having health systems take it on and say, we're going to be driving this innovation. So, you know, it's around the country now, you're seeing more of these novel approaches and more health systems amenable to innovation because their payment models have been evolving.
Angus, want to forward you if you had anything you wanted to add. We've been leaving you out here the last few minutes. I just want to make sure you.
Oh, that's. Well, look, I think we've covered, I mean, quite a bit. I mean, my focus has largely been around technology in my role, but also how does it blend in? The one thing we can't do is throw technology at the problem, though, right? I mean, longitudinal care demands integration across the continuum, right? And it's a massive data mix that we look at as a mesh. So how do we bring all that together so we have that information and can truly care for that patient? You know, historically, you know, we relied on electronic health records, but now we've got to go broader. And so how does a clinician plug into that platform or mesh and get whatever data is actionable for that N of one, that one patient? So I think I think about how can we connect all this when I look at this, but everything that folks have been saying about this, I mean, the unsustainable problem, when you look at the percentage of cost of care that results from chronic conditions. I mean, we have to do this outside the hospital. We have to engage. And 4G and 5G and you know what Cian was talking about with texting opens that door to connecting us better with these patients in underserved partnership populations and allowing us to really expand our model of care.
Very good. All right, out of fear of totally lifting the top off of Pandora's box here, I want to actually move around and go, because we've already started touching on this with with we talk about, new entrants to the market and so forth. So would love to get the group's perspective on, while we have dominant players that are focused on sustaining innovations, we have startup
Hmm.
companies that are seeking to introduce their own disruptive innovations that are less expensive, simpler, more convenient, and aimed at the lower end of the market. How are startup companies and non-traditional healthcare companies impacting our ability, the ability of organizations to continue on the same path and sustain our innovations? So, and then maybe even give us a little, Cian, you've offered a couple. Dr. Scalia, you mentioned Amazon a little while ago. Give us some of those specific examples that you're actually seeing that are where folks are coming in and frankly, chipping away at what has been the traditional healthcare system.
You want me to start off?
They're right ahead.
This is like one of my favorite topics. I mean, as an entrepreneur, I'm going to wear that hat for just a second. I think there could be no better culture medium for a startup right now. I mean, there's a ton of both opportunity and capability, which is it's a new time in healthcare. The technology insofar as, for example, AI, and that's a very commonly thrown around term now, digital transformation that we have today, it simply didn't exist 5 or 10 years ago. It just didn't exist. I mean, it was being thought of, but it wasn't implementable. And so we are now at this critical crossroads where we must pick a direction. And again, referencing Christensen, you can't really disrupt yourself well. The market is so big and there is so much opportunity to improve that I think we ought to be less concerned about the new market entrants here and actually embrace, sort of get comfortable being uncomfortable with, we don't sort of own the market. What we own is our view of it and our ability to help. I mean, I don't think any of these healthcare systems are going anywhere, but I think the way that they influence the larger healthcare ecosystem will, and it should happen. Again, unsustainable, new technologies, they're going to come fill in the gaps, show us the right way to grow and the right way to help and how to get those outcomes to improve. A one-size-fits-all approach where healthcare systems just take care of people doesn't work that well. And we've proven that pretty clearly here. And I think there's a huge opportunity to embrace this change. I think that's really, really hard. I mean, I do think, to the comments before about Geisinger Mayo Clinic building its 120-acre innovation campus, there are system-based approaches that will drive a top-down innovation that I think will have major impact. But this sort of bottom-up, smaller point solution startup approach where we're going to have multiple new entrants into the space is important. Final comment is on healthcare assurance technologies. The consumer approach to healthcare is very real. If you look at Calm, right, it's an app, which is effectively a mental health play. Is the consumer proving to us in a digital native world that people want to take care of themselves? Not only that, they want to measure it and they want to get better. That is one of the most reassuring trends that I think we've seen in a long time. And I don't know how well a healthcare system sort of top down how well they're going to do that. I think we have a new population, we have new technologies, we have new market entrants that will support the system and quilt together a future that looks a lot better in terms of quality and cost.
I just want to add to that. I think there are so many startups, as you've alluded to, and large organizations like Medtronic and GE and others, get bombarded with, innovators looking to showcase their new technology. Jeff Martha, our CEO, says, data without insights is meaningless, and insights without action are pointless. And the one thing to just consider is with the bombardment of small startups and the niches that they fill are fabulous, there needs to be scalability, sustainability, equity, and larger organizations can sometimes bring structure and process so that they can appropriately be, fit in the ecosystem, or, whatever that new process is.
I just want to applaud that response. That was beautiful.
Oh, good. Thank you. I'm glad you liked it.
Yep. No, and I truly relate to what you were saying. I'm sorry, Karen, were you still going?
No, apparently I was
Oh.
applauded, so that's good. I'm just made the
Drop
point.
the mic. So, no, but I agree, there are so many point solutions and you talked about data, right? And let's look at how we got here as a healthcare system. The Meaningful Use Act had a great goal of, improved quality through migration from paper to digital. That was great, but we ended up with a digital land grab, and now we have multiple vendors scrambling to own the data. And in the end, we're left with this big steaming pile of disconnected, uncontextualized data, right? So one piece of this is, yes, we need to figure out how we take that data and make it meaningful. We like to use the term situational awareness. And through collaboration, we need to start looking into how companies can pool that expertise. And like I think it was Dr. Scalia or somebody said, not to run from these new players in the market. Health. Another thing is we've also relied, historically on organic innovation, and we try to build, inside our single source relationships, but those limit our outcomes. So we do need to look beyond those to new partnerships. My role at GE for the last 12 or 14 years now has been specifically working with external companies. And it used to be, we're a large monolithic organization historically, and we didn't want to adopt a technology unless we acquired it. And generally that meant we'd have to strip off innovation first to put it into our own ecosystem. So it came about, probably 15, 16 years ago that we decided, we don't have to acquire these companies, but we want to leverage their innovations. And it's really made all the difference. And that's pretty much what I do all day long, is how can we incorporate this? But then, as Karen said, how do we take it so it's not just another point solution, so it's easier to integrate into that stack that you've got? So it is really important, and we've got to keep on allowing these innovations to enter.
Angus and Karen, so as the guy who has been involved with these little companies who are the point solutions, I can tell you that on this side of the house, we are telling them that if I see another point solution for diabetes or another point solution for another area, I'm going to lose my mind, right? And so what we are telling these folks is, you got to understand that healthcare can't, the total cost of ownership of trying to ingest all these multiple point solutions that all sit on top of an EHR or is exorbitant. And so moving into that platform function, which I do believe you both can very more than adequately supply, expertly supply, is truly one of the trends that we're seeing. And to Dr. Scalia's point of, what are you doing as a health system? What do you become? What are you in and of yourself, right? And so you have to answer that calculus, because then you start to look at, is this an internal build, that this is something we really want to do really, really well and innovate around? Or is this something externally we go out and we find that partner, maybe even we are an investor early on, right? We engage in that fashion. So you have that both external, internal directionality coming. And trust me, please, please, please know that we too are tired of points, and we are advocating for platforms, right? So that's, if there's any healthcare innovator listening right now, and you're thinking about like a hyper-specific one thing, make sure that it actually coincides with a bunch of other things, so that you can sit there and say, this is the chronic care management platform. This is the platform that we're running.
Well, just like, cellular and 5G, 4G has changed our ability to reach populations. I think cloud also enables us to do different things now, with our data platforms and with that ability to incorporate these in. So again, I think we have a new ability to, again, get rid of points, but yet leverage what they're innovating in.
And embrace their disruption, right?
I think,
you have to embrace the disruption.
So I think Karen's point is really smart here, and the comment around, and Cian's comment about what it's like to sort of be this point solution. One of the challenges that we face now, not wearing the innovator hat, but wearing the health system hat, is we see about 100 new point solution vendor opportunities, investments every year, right? And and they're all so exciting, right? And the problem to some degree is where does the vision go? What's the scalability is the term that Karen used, which could not be more appropriate here, because as an entrepreneur, your goal is generally to start off very small, never boil the ocean, right? Get really good at one thing. What's your beachhead? Pick the phrase that you like, and then grow to solve the big problem. Well, everyone's big problem is the same. And so many times in these healthcare vendor spaces. And so the point solutions goal is to eventually boil the ocean, right? It means this is the idea that they're all going to grow into this digital health space and serve this various elements of the massive market. So which point solutions do you pick today that will grow and scale and then sort of touch closely and integrate with other elements that you have? One of our fears in this space, here I'm using the fear, I'm not wearing the health system hat, I'm fearful of innovation. So one of our fears is that we onboard a solution today that we then dislocate in 36 months, and it took us 18 months to onboard it, right? And so the ROI that was initially contextualized, based on, when we adopted, is not only no longer relevant, it's sort of impossible. And so what we're trying to figure out is, do we actually, to a comment earlier about being patient, is part of innovation here to actually let maturity set in, but then who's the early adopter and where do these innovations start and stop so that you end up with a quilted together, healthy ecosystem of solutions that perhaps began as point solutions and not. I don't have an answer, but I will say we are pulling our hair out, as is very clear for Cian and myself, around all these different, and Troy, turns out, around all these different point solutions and where to go. We don't have enough time, let alone to hear about them, to certainly not to implement them. And so, it's a difficult game.
It may not necessarily be, which blazer you have or what color may be, preference, but as long as you have, a blazer or so it may not necessarily be that point solution, one over the other, is that much more beneficial than the one that you didn't pick. But I think the point about integration into the platform, Cian, I think you were talking about that, and Angus as well. It's the platform that's going to, I think, enable AI, predictive models, the data that comes across multiple point systems that are integrated into the platform. That is where we're going to get that learning, continuous learning is going to come off of that bigger platform as opposed to any one solution. And at the end of the day, it may not matter if you got the blue blazer or the black blazer, but you had a blazer, the data integrated in with the platform. It enabled us to learn about managing diabetes better, or heart failure, or improving our 30-day readmission rate or whatever. So, it's just another thought so that we don't get, stuck in the mud about trying to stop. We're stalled and we don't do anything because we're so worried about, should we get the blue blazer or the black blazer? Doesn't, just do it, because we have to innovate and get that data up and running so that we can make improvements and improve quality and outcomes and improve equity and do the things that the data is intended to do, not for the sake of sitting there.
Yeah, the phrase I use is I was going to say, try, don't cry, right? And so to build on what everybody said, a health system has to understand what its thesis is in terms of innovation. And if its thesis is we are going to be a late adopter, that's fine. Now you have your filter on which to be that late adopter of a mature technology that's a mature platform. As long as you're good with that and understand that, where that calculus is going to lead to you, and how you're going to also then enable taking care of your patients. I hope that maybe a health system can pivot into how do we create a construct that makes us more nimbler, and that we have the first attempt in learning, the try, don't cry. You sit there and you set up a sandbox and an ecosystem in which to bring these in. You allow them to go forward. You understand maybe 60 to 70% of what it means, because that other 30, 40% you're helping that company develop, right? And you get them moving forward, and you provide that culture and an innovation ecosystem and environment that you can embrace. So I think it's really how do you also think about your thesis in terms of innovation?
That's where I was going, Cian, is that, from an operational perspective, and certainly can relate to Dr. Scalia's point that, we're getting inundated with these different solutions as they're coming in, right? And so then as a health system, how is it that you operationalize that, right? And because you have to consider that, we don't want, when you look at, larger systems where you've got different, specialties and they're looking at different use cases for their areas, you don't want everyone to get enamored with the bright, shiny thing, right? And then next thing you know is you're looking around and you've got, 50 bolt-ons to your system. And because one, it takes a lot of resources to actually stand that up, integrate it, the training, the contracting, all these things that go along with that. When if you have some solutions that may actually reach across and actually somewhat meet those needs, you may be able to have a quicker speed to market. The other thing that I think is from our perspective, that is very much forefront is cybersecurity. And so when you start getting into integration to your EMR, that's an extensive process. And so if you start, having a lot of one-offs, you're having to repeat that process every time. And so it has to factor into that calculus as to how is it, you can, when you're evaluating solutions, what is it, again, that can actually maybe serve multiple needs versus one thing that may be the preeminent in one sub area, for instance. So we're having to spend a lot of time and establish those guardrails on our side.
Right.
Yeah,
And
Troy,
the EMR may not. Oh, go ahead, Cian.
No, I guess you go, brother.
I was just going to say, and maybe the EMR is not where it needs to reside. Something Karen said was interesting to me. Was what made me think of is you got to focus on the hub of the information wheel first, and then all these things are spokes off of that. If you get the hub right, then you just force these things to have to be able to comply with your universal platform. And if you built it right, it should be able to incorporate those. It's funny, one of the things we sell at GE are patient monitoring devices. And there are some of these really research intensive organizations where I've got to have like a dozen outputs to a dozen different systems. Each one is cost to them, and they got to manage it. If I was just inputting into that hub, then they could make that data available through a publish and subscribe service. And that's, I think, where we need to go is to really think of where do we want this to be, and then then we can focus on how those innovative technologies can attach. And then finally, and one of the other things, I don't know if you said it today, Cian, but I think you mentioned it the other day, fail fast, fail forward. You really need to be able to take those risks. Maybe you don't have to connect that technology today, but let's not let perfect get in the way of success and good when we at least pilot and do a proof of concept around these systems. I'll finish by quoting my favorite quote, which maybe is not always the way you want to do it, but Stephanie Reel, when she was CIO at Johns Hopkins, and they were looking at all these technologies, requoted the famous one that said, let 1,000 flowers bloom, and then we'll weed up 999 of them later. But let's plant these things and see what does take. As long as we've got that hub to eventually connect it to and know we can get there, we think we can scale that then.
Yeah, Angus, innovation is messy. It's not, it's not glitz and shine, it's grit and grind, right? We have to embrace its messiness, right? And in fact, that's the beauty of it, because it is messy. Some things come out of it that we didn't expect, but overall, I really truly believe, well, and then a comment on the EMR, like just real quick, the EMR was never meant to be a healthcare data can. It was created to adjudicate a claim. Right. I think that's what everybody has to understand, to take that data in and get it paid, right? Get that payment out. And now we've sort of bastardized it a little bit to contain a lot of healthcare data. Right. And so, okay, we need to think through that, but again, coming around to it, we have to embrace, innovation. It's a necessity. It's going to drive us in the direction we need to go, wherever that direction may be. You may start off over here and all of a sudden you're like, oh my goodness, wow, look at over here. But we have to get it. We have to get it done in some way, shape, or form. And then the final point, so I don't sound like too much of a ping pong ball in the dryer here, is you have to have a focused thesis. I believe that. A health system I worked with in Louisiana, we had device companies coming to us, pharmaceutical companies to us, right? We had our own venture capital and innovation funds. And we essentially said, please go read our thesis. We're software as a service, data as a service, and back-end optimization, right? All having to affect the patient care journey. If you fit into that thesis, then we would bring you through our process to evaluate. You had to solve a problem that we've identified. And then once you got through all those, you were entered into a sandbox. And that sandbox allowed you to play. And I'm telling you, never did these companies come in fully formed, right? We helped them with that formation. And so I found that these entrepreneurs not only valued potentially the investment that we were making through our venture fund, they more valued the subject matter expertise that we were bringing to the table and allow them to play in a sandbox that allowed them to grow their companies. So just thought I'd leave you there with that.
I know we've only got about 5 minutes or so left in our time before we pivot and just have some closing remarks, but I would love to kind of go around and at this point, we've kind of, our questions, we've kind of moved on past those. I think the panel would agree at this point. So I'm gonna throw one at you that is not on the list. And that would be as for our participants that are maybe becoming involved in projects that would be considered disruptive. What are words of advice or encouragement maybe that you would offer them? And I'll go first. And I think as Cian was just saying, that recognize that disruption is going to be messy. Recognize that it is not going to be. It's not always too easy to chart and to know where it's where you're heading. But I think as long as you stay focused on a true north, which is impacting care, delivering what are those, you may establish as KPIs, and it may be to reduce costs and improve access, whatever it is. But as long as you keep your eye on that, knowing that it's going to take twists and turns along the way, you'll get there. And but know that it's going to be messy. Know you're going to have to roll up your sleeves, and that it may go a lot of different directions than what you anticipated.
I think I would leave it with 3 words, and it would just be, it's a process. And, if you take away anything, just remember to create a process so that whatever approach you want to use is somewhat methodical, it's intentional, it's aligned with your thesis, as Cian mentioned earlier, or the mission of the organization. But, make sure that you create a process, and then know that it's a process and it's going to take time and it's going to be messy. And we say, innovation is painful, but it is a process. So I would just encourage everyone to keep that in mind.
I can segue from that comment. So I like that quote, that it's a process. I remember when we were starting our first company around monitoring transplantable organs, we were doing really well, really fast. And my CEO just stopped in the middle of a meeting. He's co-founder with me, and he looks and says, "Something's wrong. This is too easy." And I will never forget that, because after that, it got incredibly hard. Once we uncovered, right, we're saying something's not right. Point being, if it's easy, you're doing something wrong. It is a process, and it is sloppy, and it's difficult, and expect that, but embrace it. So my comment and my 3 words are that failure is success. So if you are moving forward, you are failing, and you will then get to success. Every time you fail, it just tells you that you're closer to yes, which is a success. And so I think as soon as you sort of adopt that, and you just liberate yourself from this notion of, oh man, we got it wrong, and you say, oh man, I now know how to get it right.
I know what right looks like. That's right.
Exactly, which is a nice segue. So I'll shut up. See you.
No, man. So what I was going to say is breathe. You're going to fail. It's okay. All right. And, I'd rather you'd be doing this and giving it a try to make a difference. And let's remember what we're all about are the patients that we take care of, right? So today, you're trying to take care of, some instances, your own family members, right? You got to remember, get back to that. What did you say? I guess the true north. Somebody said true north, right? Troy, it was you, the true north, north, right? And so right? You'd rather you'd rather somebody be giving it a go and making a difference than just sitting there and maintaining the status quo.
I'll just add, I mean, I think the first thing I thought of was, again, innovation starts with people, and especially at the front line of care. You know, I don't have to have a single original thought in my head, because every single improvement we've ever done to our solutions came from a frontline person who had an idea. We just found a way to turn it into something. And so you have such a resource. And look, I live in an IT world, and we've kind of gone from this sort of, let me pick the best thing out there. And as cost pressures and other things have come into play, we started limiting it and saying, well, I need the thing that fits in my infrastructure perfectly. I need the thing that, you know, that maybe is just good enough. And I think sometimes we need to know, is the value of what we're doing is 80% of the value derived from the last 20% of what we do. So if that's the case, then maybe good enough's not always good enough. We need to think beyond that. In the IT world I live in, sometimes we can shut down innovation from the people that could really change the game. And I think we just need to be open to listening to that incredible wealth of people that live in our organizations and go cross-cultural and cross-functional to get those to harvest those ideas for benefit to all.
Well said. Well, with that, first off, thank you to the panelists. This has been, I've really enjoyed this conversation. All of you are obviously very good at what you do and share have a great deal of wisdom, and appreciate you imparting it upon this group and myself. And to our participants, thank you for the comments, the feedback, questions, and I'll hand it over to Carter, and that's going to wrap us up.
Great, thanks, Troy. And I'll just echo what you shared, Troy, of just a phenomenal panel. I learned so much from you all, and I appreciate your moderation, Troy. I thank you, Nikki, for recording this, because I feel like I took just a copious amount of notes. I feel like I need to go back and re-review the recording. So I just really thank you all for your insights and just sharing opportunities for, you know, innovation, regardless of what your position is, you know, within a health system. So just thank you all. Panelists and Troy, please check your emails over the next coming weeks. We just wanted to share a small token of appreciation for your participation today. And finally, I want to make a quick plug, as Capri mentioned early on. We do have a upcoming ACHE networking event coming up on May 24th at Uptown Social in downtown Charleston. So just another great opportunity for us to get the chapter together to, you know, network and share ideas and have these very same discussions. So looking forward to that coming up at the end of the month. But with that, I'll pass it to you, Nikki. Thanks for having us and coordinating this event.
Thank you. So on behalf of ACHE, I just want to thank our chapter leaders that planned today's session, moderator, the panelists, and all of you for your participation. The evaluation is open for 1 week. There is a link to that in the chat, and I can drop another one in a second. You can also access the evaluation by visiting your My ACHE page. You'll select My Online Learning from the Helpful Links section. From there, you will click on Access My Courses, and you'll be directed to our learning management system where you can complete the evaluation. In that same spot, you will be able to access a recording of this session within approximately 2 business days. Everyone who attended today's event in its entirety will see their 1.5 hours of face-to-face credit posted to their My ACHE account within 2 weeks of the session in the My Education Credit section. And that concludes our session, which is copyrighted in 2023 by the American College of Healthcare Executives, all rights reserved. Thank you, everybody. Have a great weekend.
Thank you. Bye, everyone.